السلام عليكم ورحمة الله وبركاته جميعا. It is indeed my great honor to warmly welcome you all to another chapter of MENASO's Cerebrovascular Ground Round webinar organized by the MENA Stroke Organization. It is endorsed by the World Stroke Organization and the American Stroke Association and supported by Boehringer Ingelheim and Medtronic. MENA Stroke Organization is a region-wide nonprofit organization committed to a vision to reduce the overall stroke burden in the MENA region. Organizing the webinars, MENASO contributes to the comprehensive education to help the entire stroke community. The Cerebrovascular Ground Round webinar is a unique platform that provides comprehensive education about stroke, its latest treatments and management. Today's webinar, we urge everybody to write down their questions in the chat box, and there will be a dedicated session for question and answers after the two lectures presented by our guest speaker. Today's webinar will be chaired by myself and my colleague, Dr. Isam Saleh. He's a consultant neurologist at Sheikh Shakhbout Medical City in Abu Dhabi. We can now start with our first speaker, Dr. Syed Irteza Hussain, who will be talking about the relevance of the cerebral collateral circulation and ischemic stroke. Dr. Syed Irteza Hussain is the chair of the Department of Neurology in the Neurological Institute at the Cleveland Clinic, Abu Dhabi. Dr. Hussain is a consultant neurologist with 17 years of experience in neurology. After completing his medical degree from Aga Khan University, he underwent extensive postgraduate training in the United States of America. He is an American board certified in neurology, vascular neurology, neurocritical care, and neuroendovascular surgery. So we can start our first webinar with Dr. Syed Irteza right now.
Good evening, everyone. I'd first of all like to thank the MENASO organization and specifically Dr. Talib and Dr. Sohail for their kind invitation for me to present today. Again, my name is Syed Irteza Hussain. I'm a vascular neurologist and a neurointerventionalist at Cleveland Clinic, Abu Dhabi. Today, I've been asked to speak about the relevance of the cerebral collateral circulation in ischemic stroke. I have no disclosures. So let's define the cerebral collateral circulation. So it's a network of vascular channels that provide alternative routes for blood flow when the primary route fails. These alternative channels can be recruited suddenly in thromboembolic occlusions, most commonly seen by us in large vessel occlusions in cardioembolic stroke. But they can also be recruited slowly when you have hemodynamic compromise over time from progressive stenosis, as is seen in atherosclerotic disease. And then obviously, as most stroke neurologists know and interventionalists experience, these are two entities are on a continuum and there's overlap and both can occur concurrently. The biggest example of that is when you have tandem occlusions, extracranial ICA with thromboembolism, or intracranial MCA or basal artery occlusions related to ulcerated plaque, severe stenosis, and finally when the plaque ruptures at thrombosis. So we have recruitment of collaterals over time, but then suddenly we need to recruit more because of the acute occlusion. So let's define these intracranial collateral pathways. And I would like to reference Professor Liebeskin's landmark paper back in 2003 from the Stroke Journal, where he's done a very good job of defining these collaterals. And I highly recommend reading this paper. So we can divide them into intracranial collaterals and further divide into A and B as depicted here. If you look at these different views, this is basically looking at the intracranial collaterals between predominantly leptomeningeal pathways and connections between the anterior and posterior circulation. You can have connections between the ICA and the PCA via the posterior communicating artery. There are MCA, ACA collaterals. There are PCA, MCA collaterals. And we also see PCA, ACA collaterals. Around the tectum, there could be collaterals between the PCA and the superior cerebellar arteries. And the collaterals through the cerebellar hemisphere between the different cerebellar arteries can be a robust source of collateral flow when we're dealing with basilar artery occlusions. And that's the same view in a frontal plane. And then outside of the leptomeningeal collaterals, obviously, is the circle of Willis, which, or as we say, arterial circle, or the circle at the base of the brain, which can help connect anteriorly with posteriorly and between left and right. And obviously, their presence can be variable depending on whether or not the connections of the anterior communicating artery or ACA are robust, or if the PCAs are fetal in origin so that the P1 segments are small. So these can be variable and can dictate, obviously, the outcome in stroke. What I would like to highlight is when you are dealing with ICA terminus occlusions and you have a significant clot burden, then we have to recognize that those type of clots may be potentially blocking off two of the main pathways when we look at the circle of Willis. So if we take out the PCOM and then obviously the A1 segment, then there is significant disruption of the collateral pathways. And obviously that's why ICA terminus occlusions have a poorer natural course. They are more severe disease. As far as extracranial collateral pathways are concerned, these are present and they probably have more of a role when we're dealing with occlusions over time. But nevertheless, they can also have a role in acute occlusions and sometimes are of relevance when vessels are sacrificed surgically or endovascularly. So as far as the extracranial collaterals are concerned, we have connections between the maxillary artery, the meningeal artery. There are branches then that are dural based that can connect with the ACA. And then from the occipital artery, connections to the mastoid and then parietal foramen. And one very important collateral pathway is obviously the ophthalmic, and the ophthalmic connections via the meningeal artery and furthermore anastomoses between maxillary, sphenopalatine and distal branches, and retrograde filling of ophthalmics can be of importance to the ethmoidals. So within the model of ischemic stroke, it's important to recognize what is the role of collateral flow. And then we come back to the classic model of where we're looking at an ischemic core, penumbra. And after the penumbra, we have an area of oligemia, and then obviously normal tissue. Classically, we've measured the cerebral blood flow in milliliters per 100 grams per minute of brain tissue. So the normal is 50 to 55. Area of oligemia is 25 to 35. Penumbra, 12 to 22. And then in the infarct core, less than 12. Historically, the notion has been as the infarct core is irreversibly damaged. And we are trying to prevent this infarct core from expanding in size by salvaging these areas. And this is the area that is dependent upon collateral flow. So it's important to understand that the presence of collaterals will influence infarct evolution over time. And most of my colleagues who deal with stroke have seen this in clinical practice, where you have patients that arrive within an hour or 2 hours and have extensive ischemic changes throughout the hemisphere. So patient A, as depicted here, you can see that there's an entire hemispheric wipeout in a patient with poor collaterals. And where you have poor collaterals, you've lost over 460 billion neurons per minute just in 2 hours to wipe this out. Then we have a similar patient with an MCA occlusion who has sequential MRs over time, and you can see that the expansion of the infarction is very, very slow. So obviously this is dependent upon good collaterals, and the rate per minute of neuronal loss or infarct growth is much lower when you look at the second patient. And so collaterals do influence how patients present acutely and what their overall outcome is going to be. So how can we image these collaterals? There are many modalities available. Historically, before the modern era of imaging, we used a xenon CT and PET scans and different types of MRI scans, TCD, SPECT, quantitative MRA, time of flight MRA, and CTA. But nowadays, within the modern era, we predominantly use these 4 modalities. As far as non-invasive imaging is concerned, we have CTA, looking collaterals on CTA on axial cuts. This can be static versus dynamic. By what we mean by that is multi-phase CTA, where we have sequential pictures over time. And the overall literature seems to be moving in the direction of using dynamic CTA along with CT perfusion because of the ease of use. MR perfusion is obviously available and is carried out by centers that make most of their decision making based on MR. And then obviously the gold standard is digital subtraction angiography. So this is an example of multi-phase CTA, where it's divided into good collaterals, intermediate collaterals, and poor collaterals. And over different times, you can see over different phases the extent of the collaterals. So we have a left M1 occlusion, and over the 3 phases, we continue to have filling of the left MCA circulation. In the intermediate collateral phase, we can see it's not as robust. And with poor collaterals, we can see that there's very slow, delayed filling. And so that's how we can distinguish between the 3. DSA collaterals is well established, and there's a grading scale originally approved by the ASITN, and that is now used more or less ubiquitously, whereas there's grade 0, no collaterals visible to the ischemic site. And this is basically comparing to delayed venous phase. By the time the venous phase arrives, how many collaterals are filling in a retrograde fashion. Grade 1, there's slow collaterals to the periphery of the ischemic site with persistence of the defect. Grade 2 is rapid collaterals to the periphery of the ischemic site with some persistent ischemic defect. Grade 3, collaterals with slow but complete angiographic blood flow of the ischemic bed by the late venous phase. And grade 4 is complete and rapid collateral blood flow to the vascular bed in the entire ischemic territory by retrograde perfusion. And these are visible on digital subtraction angiogram when you carry out catheterizations. So as far as CTA and CTP is concerned, so multi-phase CTA showing an occlusion and showing collateral flow, and then that in itself is helping us to see on the perfusion map, we can see how that corresponds to overall mismatch, where our CBF less than 30 is showing the ischemic core, but then we're seeing a significant area of hypoperfused as the Tmax greater than 6 seconds with a favorable mismatch volume. And so this is showing us that there's collateral flow to this area, good collaterals with significant mismatch, and that this patient would be ideal for reperfusion therapy. MR perfusion basically can be utilized against multimodal imaging with diffusion weighted imaging for an assessment of the core, MRA to understand the occlusion, and then obviously using MR perfusion and Tmax maps. And specifically what has been shown to predict the status of collaterals in large vessel occlusion is something known as the HIR, or the hypoperfusion intensity ratio, where the volume of tissue that is critically hypoperfused or ischemic is taken as Tmax greater than 10 seconds. And you divide that by an oligemic tissue, which Tmax greater than 6 seconds. And so here you can see that the 6-second map, the volume is larger, the Tmax greater than 10 is smaller. So this would be somebody who is favorable for mechanical thrombectomy because they have good collaterals. Conversely, on the other side, we can see where there's a larger volume of Tmax and a much smaller volume overall of Tmax 6. And so a ratio that is smaller, so less than 0.4 seconds, is suggestive of good collateral flow and is useful for in selection of patients who would have favorable outcomes with mechanical thrombectomy. So we know how to measure this, but how do these collaterals measure up as far as the clinical state is concerned? And so we know that there's an influence of the DSA collateral flow on clinical state. So Marks et al. Published this paper in which when they published collateral score against NIH score, so patients with poorer collaterals have much higher NIH stroke scales. Likewise, when we look at they correlate that with the volume of Tmax greater than 6 seconds, patients with lower collateral scores have much higher volumes in this state. CTA collateral influence of infarct size in MRS has also been studied extensively, and this is a good paper by Seaman et al. That correlates this. And basically, when we look at the relation of infarct volumes to collateral grade as well as clinical outcome, we see that there's a strong correlation with the collateral grading. So the higher the collateral grade, the smaller the clinical, the final infarct volume, and then the NIH stroke scale. So CTA collateral influence on infarct size has been studied, as well as the clinical outcome by Seaman et al., and which is depicted in these graphs here. And what this basically again shows is that when the collateral grade is better in these patients, overall their clinical outcome is better, and this has been well studied and well described. So how about collaterals and reperfusion? So the conflicting reports in the literature may be related to the heterogeneous modalities of assessing collateral flow, but furthermore, it's important to recognize that the volume of infarction versus location of infarction influences in functional outcome too. So, and that may have a bearing on whether or not many of these studies have shown a good clinical outcome or not. Overall, if you think about it simplistically, we could kind of dichotomize the relationship between reperfusion and collaterals. What's intuitive is that if you have good collaterals in a large vessel occlusion and you have successful recanalization, the outcome should be good. Conversely, if you have a patient with poor collaterals and they are not reperfused, we believe that the outcome would be poor. And I think most of the literature does show that. Where there is conflicting data is that we have trials that have suggested, registries and trials that have suggested that Collateral status may or may not influence outcomes, whether or not the patient is reperfused or not reperfused successfully. And I think, again, part of that does matter based on the location of where your final infarct volume is. So in this instance, where we had an M1 occlusion and the patient is successfully recanalized, and there's significant sparing of the final infarct volume, we do have a significant infarct within the basal nuclei and involving the internal capsule with some mild hemorrhagic conversion. So even though volumetrically the final infarct volume would be good, potentially the functional outcome is influenced by other factors, which is the location of the lesion, and obviously if there's any secondary complications. So collaterals are important, but are not the only determining factor. And a lot of the literature does show that. Bang et al. Actually showed this nicely, where they stratified patients based on whether they had poor collaterals on this end of this graph versus good collaterals. And in patients where there was poor collaterals, obviously the infarct core is much more larger. Yes, they can have some mismatch, but there isn't a whole lot of benign oligemia. Whereas when you look on the other end of the spectrum, overall, patients with good collaterals may have much smaller infarct cores, yet significant tissue with mismatch and oligemia. So how about collateral flow augmentation? So this is an intense area of research. And yes, in this era of mechanical thrombectomy, obviously thrombolysis and mechanical thrombectomy, when we're dealing with large vessel occlusions, it's all about speed. It's all about assessing the patient quickly, making a decision, administering TPA if and when indicated, and then speeding off to the angiography suite to recanalize the vessel and reperfuse the tissue. But what about endeavors outside of thrombectomy or in the time building up to thrombectomy? Are there other endeavors? So this has been a lot of these treatments or potential factors that can influence outcome have been studied. Head positioning has been looked at. The head post trial failed to show any difference. But when we actually measured blood flow in these patients, yes, keeping the head down does improve blood flow to the ischemic tissue, but we have not been able to show that it influences outcome. Likewise, blood pressure. Stroke guidelines currently allow for permissive hypertension up to 220 by 120, at least in the American Heart Association stroke guidelines. And additionally, if there is thrombolysis, obviously it's less than 180 by 105. But there's been extensive area of research on whether inducing hypertension or permissive hypertension and acute occlusions can help. Within the era of thrombectomy, there's been extensive research into the influence of general anesthesia when we induce general anesthesia and its influence on MAP and what it does to cerebral perfusion and what it does to outcomes. And obviously, this is an area of intense research where we want to optimize collateral flow while we're leading up to mechanical thrombectomy. Volume status of patient, which again, hydration is key and is important. There's some landmark data from the early days of stroke where just delivery of a liter of normal saline had influence on infarct volume and clinical outcome. Recently, there's been study of volume expanders and looking at albumin, which has been a negative trial. But these initiatives have failed to show clinical benefit. But when we look at overall blood flow, we believe that some of these factors may influence. And so, especially as we're getting ready for mechanical thrombectomy, focusing on blood pressure, for perfusion and hydration status is important, but perhaps there's going to be more important role during and after the procedure. Finally, as far as medications are concerned, there's a lot of data about the role of statins and their influence on collaterals, which is obviously more relevant in patients who are previously on statins, who have underlying atherosclerosis. And there's some basic science research and clinical interest in the use of nitric oxide as something that can help improve collateral flow. But it's important to understand that when we are assessing collaterals, we have to look at collaterals over time. So if a patient presents to you right now with a large vessel occlusion, with significant clinical imaging mismatch or perfusion-based mismatch, that tells you that, okay, this patient is okay right now, the collaterals seem to be working right now, but there is risk that these will deteriorate over time. And we know from the natural course and the natural history of large vessel occlusions that patients with large vessel occlusions will deteriorate over time. So it's important to understand that collateral flow in acute large vessel occlusions is dynamic. It's influenced by other factors. And what is good now may not be good later. And this is of relevance in clinical practice when we look about patients with LVO who have a low NIH stroke scale. So historically, when we look at the pivotal trials for mechanical thrombectomy, some of the trials, especially Mr. Clean, MR Clean, included patients with very low NIH stroke scales. And it has been well documented that mechanical thrombectomy makes a difference across the whole spectrum of NIH. But some trials did exclude patients with low NIH stroke scales. And that's been an intense area of debate and research. What do you do with somebody who has a proximal MCA occlusion and low NIH stroke scale? Whether or not they get TPA, if they're within the window, they'll be thrombolized. If they're not within the window, what do you do in that scenario? Do you treat the occlusion? Do you take them now? Do you wait till they deteriorate? And that's an intense area of research. And a lot of the natural course of the disease that's been published by many colleagues is that a lot of patients with large vessel occlusions may deteriorate later, and that there's a window of opportunity to act now. So it's important to recognize the concept that yes, you have collaterals that are good right now at this moment in time, and that your infarct is small, but overall there is risk that this will change over time. And most recently, there's been a very nice paper on JAMA Neurology looking at this, and where in patients intended to be treated with IV TPA with large vessel occlusions and low NIH stroke scales, when they looked at what predicted early neurological deterioration secondary to ischemia, they only found two relationships. One was the site of occlusion, and the second was the thrombus length. And actually, collateral flow or collateral status did not have any influence. It was not able to predict who was going to deteriorate or wasn't going to deteriorate. And so that's where, yes, collaterals are important, but not the only determining factor. And as we know, that patients with proximal large occlusions or tandem occlusions or basilar occlusions, these are the patients that will deteriorate. And as it has been shown previously, that the longer the thrombus length, the probability of deterioration is higher. And this highlights the importance of recanalization and reperfusion of the ischemic tissue. So yes, the collateral status in the acute large vessel occlusion scenario is important, but is not the only predicting factor. And we have to really think about recanalization and reperfusion. So what is the final message? Collaterals preserve tissue in the acute ischemic model. We know that. Collaterals influence infarct growth and final infarct volume. However, it's successful reperfusion strategies that determine the final outcome. Finally, additional research is ongoing, and augmentation of collaterals to improve outcome is where a lot of the research is going to be done. As you all know, mechanical thrombectomy has been established as a treatment. We can open vessels and we can open them fast. The next frontier is what can we do to preserve tissue while between the decision making and the treatment, and how can we continue to promote flow and prevent secondary neuronal injury after reperfusion. And I think collateral flow and obviously a lot of basic science research that is being done is going to help assist us with looking at the influence of collaterals and neuroprotectants in these patients. So that concludes my talk here today. And once again, I thank you all for listening, and I thank MENASO for the opportunity. And I'm happy to take any questions when we're in the question and answer section. Thank you.